So let's move on to another assessment question. MM is an 82-year-old female with a past medical history of peripheral artery disease and atrial fibrillation. Which below is the most appropriate choice of anticoagulation in this patient? So we'll take a minute, and then I want to definitely touch on a few things in relation to this question. Can somebody from Augusta tell me what you think about this question?
Multiple choices.
Okay, so let's kind of talk through that and kind of delve into things. So if you were going to be assessing this, there's a specific score that you would likely want to use to work this patient up. So can somebody from Savannah tell me what that score is? What score are we talking about here? Yeah, so the CHADS-2 VAC score. The new test guidelines for the management of atrial fibrillation actually came out within the last month. So I think that's an important point to touch on here because they are a little bit different. So basically the new guidelines, one of the biggest things that the new guidelines say is that they do recommend DOAC therapy when able over warfarin therapy or vitamin K antagonist therapy. That being said, there are certain populations where it does remain inappropriate to use the DOAC agents. So one of those is cancer and then our valvular AFib patients. So keep that in mind, that is something new in the new guidelines. So if we kind of work through this, can somebody tell me from the Savannah campus what MM's CHADS-2 VAC score would be?
She's old.
Four, yes, absolutely, that's correct. Do you mind explaining how you got to that so everybody's on the same page?
She's a female, which gives her 1 point. She's 82 years old, so that gives her 2 points. That's 3. And then she has AFib, so that's another point.
So the CHADS-2 VAC score is used specifically for patients with atrial fibrillation. So that 4th point is actually going to come from her peripheral artery disease, but her score is 4. So we know that based on her score that anticoagulation is appropriate. So what the new guidelines say is they basically break it down into a non-sex versus a sex score. So that meaning that if your sex score, so taking female into account, because right off the bat as females we're going to have 1 point, right? So if your sex score is 1, so that's going to be a 1 for a female or less, so a 0 for a male, they recommend no anticoagulation. That means no aspirin and no anticoagulation. Okay, so then if you do have a non-sex score of 1 or more, so basically we're looking at a non-female related risk of some of the things that we just mentioned, then that's when we start getting into our oral anticoagulation is recommended for the guidelines. So we know based on that that A is not going to be appropriate because we know that her score is 4. Going down the line, we have apixaban. So we just talked about how the guidelines do recommend DOAC therapy over warfarin therapy. We don't see anything here about active cancer that would exclude her. However, is this the appropriate dose of apixaban in atrial fibrillation? No. So there's a few things that we don't know. Remember that this is dose reduced based on for age and things like that, but it's either gonna be 5 milligrams a day, or if she met 2 of those 3 criteria, remember, then it would be 2.5. So either way, we know that 10 is not gonna be appropriate. So that's basically going to leave warfarin as the only option for MM. So be thinking about these things as you go through. You definitely want to be familiar with the TAS2 score. That's why it's working. So this is just a little bit refresher about warfarin dosing. Warfarin is a very personalized and individualized drug when it comes to dosing. The only time that you're really going to have a strict recommendation like this is when you're starting somebody right off the bat on new therapy. So the guidelines do recommend 10 milligrams for the first 2 days. An argument can be made in older or patients with more comorbidities that maybe even a 5 milligrams a day for the first few days would be appropriate. And then after that, you basically move to an individualized approach based on that person's INR. Okay, so let's take a look at this. Can somebody from the Augusta campus read this question?
Why?
Sure. Present it, Austin, go.
It's decided that MM will be initiated on warfarin therapy. She has no history of thrombotic events, but does have bioprosthetic mitral valve. Which of the following is the appropriate INR target for MM?
Perfect, thank you so much. Okay, so can somebody from Savannah say what they think the answer to
I'm
this
so
is
confused.
and
Why did we have to
why?
read the question to her?
You did a really good job, though.
Now, do you want to say to, before we go over this, that when to use what range for warfarin is definitely something that I want you to be able to recall without resources as well. So I'll say that again, want to make sure that the appropriate ranges for INR monitoring for patients are something that you are able to recall. So what do we think for MM?
I would say
2.5 and 3.5 because she has a valve.
Okay, so we want to take a few different things into an account. So you're correct, she does have a bioprosthetic valve, and we want to look at that a little bit closer. So the only time that we're going to use this higher INR range of 2.5 to 3.5 is when we have a mechanical mitral valve. So because this patient has a bioprosthetic mitral valve, her range is still going to be 2 to 3. So for bioprosthetic mitral valves, it's still going to be 2 to 3. That's the same with bioprosthetic aortic valves. That's the same with mechanical aortic valves. We are concerned and we shoot for that higher range when we're talking about mechanical mitral valves, is when we would shoot for a 2.5 to 3.5 range. The reason for that being, what we worry about with atrial fibrillation is the pooling of blood in that left atrial appendage. This has shown to be, we're worried about the mitral valve the most. That's where the worst cardiac outcomes are seen if that is not managed appropriately and if a clot is to form there. The mechanical valves are less similar to the anatomy of a human valve than our bioprosthetic valves, right? So that's why we're a little bit more concerned when it comes to a mechanical mitral valve, and why we want to shoot for that higher range. So before we get into some of the individualized medications and foods and things like that, I do want to talk about some patient factors. Warfarin overall is highly variable. It makes it a great opportunity for pharmacists to be involved in terms of the management because it really is very patient specific. So these are just a few things that can affect your patient on an individual level. One of those being age. We know that as a patient's age, all of the ADME properties are going to be potentially altered and different in our aging populations. Varying size, as well as fluid status, and we will talk about a few other disease states at the end. But when you think about fluid status, you want to think about how our volume of distribution changes, and keep that in mind when you're thinking about drugs that affect fluid status, such as our diuretics and things like that. If somebody is hanging on to more fluid, that drug is going to be dispersed over a greater area, and when it comes to warfarin, because of that, you may see a lower INR. So in the same token, if somebody is started on a diuretic, you may even see their numbers start to go up as some of that fluid starts to come off. So also genomic variants. So we talked about in the pre-lecture how warfarin is metabolized through a few different CYPs. So you want to be aware that depending on variants in those CYPs, certain people could metabolize warfarin differently than others. That being said, the guidelines do recommend against routine genomic testing. So if you are involved in the monitoring of warfarin of a patient, it's likely that you will not have that genomic data available to you. But be aware if you start to see fluctuations in the INR that you can't attribute to anything else, that it is possible that they have some type of genomic variation going on. So this is going to be our interaction key. I hope that this is helpful to you. We're going to kind of use this throughout the whole lecture. So what we have here is our purple arrows for increase and decrease. This is going to be a potential increase or potential decrease. So this is not something where right off the bat you're going to adjust the warfarin dose. You may just monitor them a little bit more closely, and I want to specify what I mean by that. So with the INR testing, that's how we make sure that our patients are in range, right? So the guidelines say that for stable patients, that their INR can be tested up to 12-week intervals. A lot of times clinics will monitor them more closely. Intervals of 4 to 5 weeks is a lot more typical. So what I mean by increased monitoring or closer monitoring is if you are the one monitoring that patient in a pharmacist-run clinic, making sure you bring them back sooner. If they were started on medication that's related to a purple arrow, maybe 1 week, maybe 2 weeks, depending on the patient situation, and just monitor them for changes. Our red arrows, both up and down, are going to be our more serious interactions. So these are going to be things that for a lot of these medications, right off the bat, if you have a patient starting on one of these medications, you are going to adjust the warfarin dose when you realize that a patient has started on one of the medications associated with the either up or down red arrow. So something I do want to say before we get started, in terms of other things that you should definitely be aware of, I want to make sure that if at any point there is a medication bolded on the slide, that you at least have an idea of whether that medication increases or decreases the INR and how worried we are about it. So if a medication is bolded on the slide, definitely commit that to memory in terms of what that medication is going to do to the INR and how worried about it we are. I will point out if there are specific medications that I want you to remember the exact percentage of dose reduction for that medication. So again, I'll let you know and I'll reiterate it, and please let me know if it's unclear exactly what medications you need to memorize the percentage of which we're going to dose the warfarin or dose reduce or increase the warfarin when a patient is started on. Does that make sense to everybody? So we are going to start with our analgesics, and for the most part in this section, we're going to be talking about acetaminophen. That's because we're going to talk about our NSAIDs later. So low doses with these medications are going to mean minor bleeding, and especially when it comes to aspirin, sometimes that minor bleeding is desired. So for the most part, we want to make sure that patients who are on warfarin are aware of the signs and symptoms of bleeding, because it's usually going to be not appropriate for them to have signs and symptoms of bleeding. Sometimes aspirin can be used concomitantly with our anticoagulants in certain patient populations, but for the most part, we want to make sure that patients are avoiding things that are going to increase their bleeding risk. So when we talk about Tylenol, we are not as concerned about patients who just take a few Tylenol once in a while for the occasional headache. Where we become concerned is patients who are taking doses greater than 2 grams of Tylenol a day, especially for multiple days in a row. Your opioids, when it comes to your INR, are a little bit safer than acetaminophen and aspirin because the bleed risk is lower. However, we're concerned about opioids for other reasons, right? And a lot of other things we have going on currently. But in terms of the effect of the INR, with the exception of tramadol, opioids really aren't going to affect our INR too much. So that's definitely something to be aware of there. One of the biggest clinical pearls here that I want everybody to be aware of is counseling patients about OTC products. So that's definitely important, especially in the community or retail setting. A huge opportunity for us as pharmacists, making sure that patients are reading the back of their labels. A lot of times people don't know that certain products contain acetaminophen. People don't know that acetaminophen is the same thing as Tylenol. So make sure we're educating our patients who are on warfarin about reading their labels and what to look out for. So next we will talk a little bit about our absorption inhibitors. And I listed the specific ones here that are most likely to have the effect on warfarin. So we have a purple arrow here, so a potential to decrease the INR. This is because it's going to change how warfarin is taken up in the GI tract. So that is possibly, you may see a reduced INR. And again, we're talking if somebody comes in and they started on one of these medications, you don't need to reduce their warfarin dose right off the bat. You just need to be aware that they started one of these medications. Maybe have them come to your clinic or let the provider know who does monitor their warfarin that they should come in maybe 2 weeks rather than 4 weeks to see if it's had an effect on their INR. We do have a few other options here, and I will try to highlight that when I'm able to. There's a lot of these classes where there are options that don't have an effect on INR, so if at all possible, you may want to consider using one of these agents. So as you can see, we do have a few other options here. And you want to monitor the response in these patients and just adjust the dose if necessary. And it's going to be very individualized. So you want to make sure that you give your oral anticoagulant, so your warfarin, either 2 hours before or 6 hours after one of these agents to minimize the effects. So I'll say that again. We're talking about giving the anticoagulant either 2 hours before or 6 hours after the absorption inhibitor, to make sure that you are minimizing the effect of this drug interaction. Okay, so next we have some of our enzyme inducers. So I bolded the ones here that are going to be most prominent in terms of the interaction and also in terms of what you're going to see in practice, regardless of the setting that you're practicing in. So a lot of these that are unbolded are not frequently used. The ones that are bolded, I'm sure you've kind of seen more commonly even throughout school. So just be aware of that. And I put a purple arrow here because it really does depend on the enzyme inducer in terms of the effect. So one that is a big one here is going to be your primidone. So the primidone specifically requires an adjustment of 30 to 60%. So I'll say that again, definitely something you want to remember. The primidone specifically does require a dose adjustment of 30 to 60%. And that gives you a little bit of a range. So can anyone at the Athens campus tell me why you think a range in the dose adjustment recommendation is so appropriate rather than a set like 40 or 50%? So I'll repeat the question. If someone from the Athens campus can tell me why you think it's important and recommended that we have a range for adjustments rather than a set reducing or increasing a dose by say 40 or 50?
Because each patient is different.
Yeah, absolutely. Each patient is individual. We talked about those effects that can change the individualized response to warfarin, as well as the fact that when somebody comes in on one of these medications, people's baseline INRs before they start these medications are going to be different. So when someone comes to your clinic and they start one of these medications where you are supposed to adjust your dose 30 to 60%, well, you may not have to do that if their INR is already really high or really low to start with. So you want to make sure that you are taking that into consideration. So we're talking about enzyme inducers here, so this is going to be a gradual reduction through our CYP, so this is going to be a CYP-related interaction, right? Azathioprine, the mechanism behind how that affects the INR is more unknown. Phenytoin can also have some competitive binding effects, which can kind of stack up the reasons in terms of why you may see this drug interaction. We want to also be aware that it can take 1 to 2 weeks for maximal effects of some of these interactions, and sometimes 1 to 4 weeks after the medication was discontinued. So the important thing here is consistency. You want to make sure that your patients are telling you about all of their medication changes. So we talked about the fact that usually patients are only followed every 4 weeks. Sometimes, according to the guidelines, it could be up to every 12 weeks. So can someone from the Savannah campus give me a reason about why it's so important to make sure your patients are giving you updated medication lists and things like that? What are we concerned about if we're only following our patients every 4 weeks or every 12 weeks? Yeah, absolutely. So if you're only following somebody every 4 weeks, or if you want to repeat that to the microphone.
Drug interactions?
Thank you very much. So yeah, so if we're only following somebody every 4 or every 12 weeks, and they start on a new medication a week after the last time we've seen them, that's not good if we're not catching that interaction until 3 weeks later. So it's important to educate patients on calling the clinic if they have a new medication added to their list in between appointments. I also always tell patients at our anticoagulation clinic to make sure that we're asking them and that they're calling us with not only new medicines that are being started or stopped, but dose changes in those medicines too, because that can make a huge difference. And I do want to clarify one thing. When we're talking about dose adjustments here, so for the Primidone 30 to 60%, we are talking about a dose adjustment to the warfarin, not Primidone. Okay, so we want to make sure that patients are taking the medications that control their other disease states appropriately, and we will alter their warfarin to match that. So when we're talking about dose adjustments, what you would usually do is calculate the weekly dose of warfarin for the patient, and then either reduce it or increase it by the appropriate percentage. So you make the adjustment to the warfarin. Okay, so let's talk about some of our statins. What we worry about here is a potential increase of the INR. I do want to highlight that this is absolutely a potential increase on the INR. It's oftentimes negligible, so it is not necessary to decrease or change a warfarin dose based on a patient being on a statin. We know that there's a lot of evidence behind our patients being on statins, and we want to make sure that we're keeping those patients on evidence-based therapy, right? So we do have a few options here. Why are we more concerned about, say, rosuvastatin than we are atorvastatin interacting with the warfarin? Does somebody from the Augusta campus want to give this one a try? So why are we more concerned about the rosuvastatin interacting with the warfarin than we are maybe the atorvastatin? Think about which of our SIPs are the more potent SIPs when we're worried about warfarin, right?
Is it because rosuvastatin goes more through CYP2C9 than atorvastatin?
Yep, absolutely. Thank you very much. You're exactly right. So atorvastatin does go through 3A4. We are a little bit worried about 3A4 because warfarin still goes through 3A4, but not to the same extent of which it goes through CYP2C9. And we know that atorvastatin and rosuvastatin are our two options for our high-intensity statins. So we want to make sure that we still have a high-intensity statin option to put patients on if they're having an issue with this interaction. So if you had to choose between atorvastatin and rosuvastatin, atorvastatin may be more appropriate. We have some others here that may be recommended. Pravastatin is a little bit less metabolized through the CYPs, so that is an option. But again, we don't have a high-intensity option with pravastatin, and we know in a lot of our patients that high-intensity statin is really what we need to get them to where they want to be in terms of the management of their other disease states. Okay, so let's talk about our azole antifungals. So we have a red arrow here. So this is going to be a class-related, specifically for the ones mentioned here. Absolutely, right off the bat, dose adjustment to the warfarin, okay? So this is going to be through CYP inhibition as well. Non-oral formulations such as IV and things like that have also been shown with our azole antifungals to affect the INR. So you're going to automatically reduce your warfarin by 10 to 20%. So I'll say that again. So if somebody is on one of these azole antifungal antibiotics, we are going to reduce the warfarin dose right off the bat 10 to 20%. So add up that weekly dose of warfarin for the patient and reduce it. We do have some other options here that have been shown to have less evidence in terms of the drug interaction. So you could consider not dose reducing for some of these alternatives, but for the ones that we just listed on the previous slide, you need to remember this dose reduction. Always ask patients for updated medication lists for all antibiotics, for all medications like we talked about before, and even short time use. Because sometimes, especially with fluconazole, patients may only be on a 1 to 3 day dose of the fluconazole. They still need to let us know about it or let their provider who is monitoring their warfarin know about it. Yeah.
So do you, and for how long do you adjust their dosage?
Very good question.
If it's the first of one dose or first for 2 weeks?
That's a great point. So we're going to be less concerned if somebody is on like a shortened course, so a 1 or 3 day course. We'll have a patient case that talks about it too, but if somebody was only on fluconazole for a day, I would probably only reduce that specific day's dose of warfarin. So I would say if you take a full tablet today, take a half tablet. You want to take a bunch of things into consideration, including the last time they were at your clinic and what their INR was then. So if somebody's goal range is 2 to 3, and they were at my clinic Monday and their INR was 1.9, and now they're taking a 1 day dose of fluconazole today, I probably would not dose adjust. Because even if it goes up a tiny bit, I'm not really worried about it. They were in range anyways. But for therapeutic patients, for a 1 day dose of fluconazole, even for a 3 day dose, I would probably say, okay, let's take half of your warfarin dose today. Anything beyond that, like a 1 week or a 2 week course of antibiotics, then you would add up your dose, take the 10 to 20% off the top for the weekly dose, and do that for the duration of the fluconazole or the medication that they were on. So for the most part, no. We will talk about some certain situations in which you do need to do that because of the half-life of some of the medications that do interact with warfarin. So in this case, you don't need to prolong it after they're off the fluconazole. You would do the dose adjustment of the warfarin for the time that they're on fluconazole, and then once they were off the fluconazole, you wouldn't be worried about it anymore. Any other questions about that? It's definitely an important concept. That was a good question. Okay. So next we will talk about cimetidine specifically. So this is a highly variable interaction among patients. I do have it here as a red arrow because there is a lot of evidence to show that this interaction does happen. However, you still may have some patients in which you do not see them respond to this at all. This is through inhibition of CYP2C9. I do want to point out here this extensive list of medications that do not have this interaction that could be used in these patients instead. So if you do have somebody who's on warfarin, we have a lot of other options. If possible, you could pick a different H2RA, you could pick a different PPI, and really kind of avoid this interaction altogether. You just, again, want to make sure that you're monitoring these patients and that they're making you aware of any changes in their doses and things like that. Okay, so let's talk about some more antibiotics. There's a few specific ones that I have listed here. So this is definitely going to be a red arrow. So I do want to point out that all antibiotics can potentially increase the INR. So if you were to put almost any antibiotic into a drug interaction checker in Lexicon, it would probably come back as a category C or monitor therapy interaction. So you have to be aware that depending on your patient, you could really see an increase in INR from any antibiotic, and that's going to be patient dependent. The ones that I have listed on the previous slide are going to be the ones that you're going to want to consider a 10 to 20% dose reduction for. The most common one of these that's used is probably the sulfamethoxazole, and this is the one where that adjustment recommendation really has the strongest piece of evidence. So I would like you to remember that. So specifically for the sulfamethoxazole, that the dose reduction for that is 10 to 20%. So 10 to 20% for the sulfamethoxazole. So definitely something that you want to keep an eye out on, and this is again kind of how we just talked about with fluconazole. If you have a patient who has started on Bactrim, you would basically make sure that you're looking at their weekly dose of warfarin and adjust it right off the bat. Does anyone have any questions about that? So next we will talk about some of our antidepressants. This is a purple arrow, so potential increase of the INR. This is going to be through inhibition of CYP2C9, so kind of a common trend here, right? So most of these interactions are going to be CYP-related interactions. A lot of times this is going to be a gradual increase in the INR, usually over a 7 to 10 day span. So you want to make sure that you're keeping in mind the other SSRIs besides these ones that don't have as big of an effect on the INR. But I would like to point out that all SSRIs can potentially increase the bleeding risk. So let me ask a question to the Albany campus. Do you think that if a medication is causing somebody to bleed excessively or to bleed more than we would like them to, do you think that is always reflected in the INR? So I'll repeat that question. So if somebody is at a higher risk for bleeding, or if somebody is bleeding, do you think that that is always going to be reflected in the INR? So will the INR always be higher if somebody is having abnormal or undesired bleeding?
No.
Absolutely, you're correct. So that's an important differentiation to make. There are some agents that can increase the bleeding risk of patients who are on warfarin therapy, and you will not always see an increased INR. So although we have other SSRIs and other antidepressants here that will not affect the INR, the increased risk for GI bleeding is a class-wide effect of all SSRIs. So that's not to say that giving one of these other agents is without risk. You're just less likely to see a fluctuation in the INR. So let's talk about a little side note about bleeding. So if you were working in a pharmacist-run anticoagulation clinic, and let's say that you had a patient who was on an SSRI, maybe one of the SSRIs that does not affect the INR, what signs and symptoms of bleeding would you tell your patient to look out for? Like, what are we worried about? Does somebody from Athens want to give this one a stab?
Maybe a change in the stool like melena or hematochezia.
Yes, absolutely. What else?
Bruises that may not diminish over time.
I'm sorry, what did you say?
Bruises that may not diminish over time.
Yes, so she said bruises that may not diminish over time. And that is true. So we want to make sure we're educating patients that as bruises heal, they should turn blues and greens and things like that. Bruising has been shown in the evidence to be linked to potential for an increased risk of more serious bleeds. The most serious bleed that we're worried about in patients on warfarin is definitely going to be if they hit their head and start bleeding internally. So that's something where if a patient has a cut on their arm that takes a little bit to stop bleeding, okay, call our clinic and make sure that's something where there's not an on-call service at the clinic, then it's okay if you get that voicemail and talk to them about it in the morning. But a hit your head while you're on warfarin is an absolute, you need to go to the emergency room and get a CAT scan because we want to make sure that patients aren't messing around with bleeding internally, especially intracranial bleeding. So let's talk about some of our enzyme inhibitors. So I bolded the ones that are probably going to be most commonly seen. So remember, bolded agents are one that I want you to definitely be able to remember that they are enzyme inhibitors and what their effect is going to be. And I will tell you if there are specific ones that I want to make sure that you know the actual dose reduction for. So this is going to be a red arrow. So we're worried about a high risk of an increased INR. This is going to be through, no surprise here, inhibition of CYP2C9. Amiodarone can also increase circulating thyroid hormone concentrations, which has been linked to increased INRs as well. So kind of a little bit of a dual mechanism there. These medications that are listed in red are definitely dose reductions that I want you to be able to remember. So that's going to be the valproic acid, the fenofibrate, and the amiodarone. Notice here that these are all ranges, so it's patient specific. So for fenofibrate, if you can't remember it's 27 to 42, and you just remember it's like 20 to 40%, totally fine. Just know the ballpark of what we're talking about in terms of the dose reduction here. If you're thinking about a patient's weekly warfarin dose, and that at most, are we going to tell our patients to cut a warfarin tablet into quarters? Probably not. So is that going to be feasible to reduce the dose by 27%? That's very specific, probably not. But you do want to know these kind of ballpark dose adjustments for patients. Probably the one that comes up most commonly is going to be our amiodarone. I have this clinical pearl here for amiodarone, so it's very important to remember that this interaction may take several weeks to develop, and in the same token, it may take several weeks for that interaction to subside after a patient is taken off of the amiodarone. Any questions about that or of the dose reduction for these medications? Okay, so next we will talk about our NSAIDs. So all NSAIDs are going to inhibit platelet function. So we can assume that this is going to be a potential increased effect on the INR. Aspirin's a little bit different because it's going to irreversibly inhibit platelet function, whereas some of our other NSAID agents are going to be reversible. The biggest concern here is GI bleeding. So although you may not see a huge increase in the INR in patients who are on warfarin and co-committant NSAID therapy, there's a very high risk of bleeding for these patients. So please keep that in mind, that even though it is a purple arrow, that it's a very big education point that patients are aware that they should avoid taking NSAIDs if at all possible. Tylenol is going to be a safer choice than our NSAIDs for patients on warfarin. even though Tylenol may be more likely to increase the INR, it's less likely to increase bleeding risk, which we talked about a few minutes ago, why that's concerning and when that's most concerning. So there are a few different options here that do not affect the INR as much. We talked about non-NSAID analgesics. There are some other agents like the celecoxib, however, that has also been shown to increase risk of upper GI hemorrhage. So again, here you kind of have to weigh things and look at your patient as an individual and look at the other things that they may be at risk for. So let's talk about our thyroid products. Specifically for this is going to be levothyroxine. So levothyroxine itself can potentially increase the INR. This is kind of a little bit of a combination of both a medication and a disease state interaction, because hypo and hyperthyroidism on their own, regardless of the use of levothyroxine, can have an impact on our INR. So there's a few different thought processes in terms of why that might be. I have listed a few of them here. Hypothyroid patients may be metabolizing clotting factors slower, orphan protein binding may be decreased in hyperthyroidism, and thyroid hormone may increase the affinity of the vitamin K factors. So you want to make sure that you're monitoring them and adjusting if necessary, and making sure that you're keeping an eye on those lab parameters, because just because somebody is on a stable dose of the levothyroxine, if their labs are fluctuating, if their TSH and their free T4 are fluctuating, even though their dose is the same, you may still see differences in their INR based on that disease state interaction. So again, ensure that your patients are telling you about any updates in their medications. This is another one where people can be changed in their doses somewhat frequently. So keep an eye on that and make sure that your patients are making you aware of any changes. Okay. So next we will talk about some of our herbal and over-the-counter medicines. Before we get to that slide, does anyone know when it comes to herbals, there's a specific letter that some of the herbals begin with that we're most concerned about increased bleeding risk? Someone from Spain want to take a step?
G.
Yes, absolutely. Thank you so much. And that is going to be something that is often discussed on board exams and things like that. You want to make sure that you are looking at all medications when it comes to interactions with warfarin. I know at our anticoagulation clinic, even pharmacists who have been doing anticoagulation for more than 10 years, when a patient's on a new medication, they always look it up because you never know. There's a lot of ones we wouldn't expect that have interactions. We talked about the big ones during this lecture. But especially when it comes to those herbal and OTC products, sometimes we don't have any evidence, which is unfortunate, especially with essential oils. I had a patient the other day who was drinking essential oils. There was a lot of different stuff in those essential oils, so you have to make sure you're careful in monitoring those patients. But yes, we worry most about herbal products that begin with a G. And these are kind of those big 5 G herbal products. So are we worried about a decrease INR or an increased INR? So if a patient came in and had started on ginger root, would you be concerned about a decrease or an increase in that? Someone from Savannah want to go ahead? Yes, absolutely. So we are worried about an increase in the INR. So this is going to also be an increased bleeding risk. You want to consider avoiding these agents if possible. And we want to make sure we're educating our patients, as always, right, that some of the herbal medications have less evidence behind them. So you want to make sure that you're not being demeaning or discouraging for people wanting to make certain health choices, but at least make them aware that we have a little bit less information in terms of how some of these things might affect them and affect the prescription medications that they are on. I do have vitamins on here as well. Why are we worried about vitamins? Does somebody from Augusta want to take a stab at why we might be worried about multivitamins when it comes to warfarin?
Some of them will have vitamin K.
Exactly. So some of our multivitamins do have vitamin K. It really depends on the formulation that the patient is on. Some of them have a rather negligible amount, or some of them might have a lot more. So that's another opportunity to educate our patients on the importance of consistency and making sure that they are not changing their multivitamin. Pick one and stick to it, because regardless if you're on a medication that increases or decreases your INR, the warfarin dose that you're on is set up to be stable for those other things that you're on, for the medicines that you're on, for the diet that you're having. So if you have a multivitamin with a lot of vitamin K in it, that's okay. You just want to make sure that the warfarin dose that they're on is compensating for that. They may need a little bit more warfarin when they start that vitamin, and then as long as they hopefully don't make any changes, we'll have a stable INR for the time that they're on it. Any questions about that? So let's talk about VB. So I will read this case, and then for the rest of the cases, I'll ask for volunteers, so it can be a little bit more interactive. So VB comes to your anticoagulation clinic. She takes warfarin 5 milligram tablets, 1 tablet daily. She's very concerned as she was given 1 dose of fluconazole for vaginal candidiasis 1 week ago. She didn't take it because she was worried about how it would affect her warfarin numbers. She asked you how to proceed. So what do we think? Someone from Savannah, what are your thoughts? Or what questions do you have? Do you need more information? So how do we educate patients who are started on a new medication and are scared that it's going to affect their warfarin, so they don't take it at all? And that might be more common than you think. So what do we want to tell VB first of all? What about somebody from Athens? What do you think? Somebody from Athens, what are we going to tell VB about her being worried to take medications that affect her warfarin? Somebody from Savannah want to help out?
Some medications are okay to take, that you just need to know about it, and you can make dosage adjustment, the proper adjustment.
Absolutely, so that's perfect. So take the medications that you're supposed to. We don't want you to be having uncontrolled issues, uncontrolled infections. Just let us know and we'll adjust your warfarin accordingly. So somebody from Athens want to help out with fluconazole. What is our dose reduction recommendation? So we're going to dose reduce the warfarin for fluconazole, and what is that percentage recommendation?
10 to 20%.
Exactly, 10 to 20%. So like we were saying before, we're going to be a little bit less concerned in this situation because VB is only on the fluconazole for 1 day. So we're going to take into account what her INR was the last time that she was at our clinic and how long ago that was. And then from there, we're going to say, okay, please take the fluconazole. It's very important. If you take 1 tablet today, the last time you came to our clinic was last week, your INR was 2.7, your goal is 2 to 3. Why don't you take half of a warfarin tablet today rather than a full one, and then come back in maybe 2 weeks? Does that make sense? If she was on fluconazole for longer, so let's say she was on fluconazole for a week, we know that she is on warfarin 5 milligram tablets, 1 tablet a day. So how many milligrams of warfarin is BB on for the week? Yep, so how would we reduce her dose if she was on fluconazole for the whole week? Yeah, that would be fine. So we'll put her on 30 milligrams. You kind of have to figure out, you want to make sure you're telling them a reasonable way to adjust that, right? We're going to either do hold a whole tablet or half a tablet, never smaller than half a tablet. So keep that in mind. And then if people are on antibiotics for a week or longer, probably want to have them come to the clinic shortly after they stop that antibiotic to make sure that their INR has stabilized. What questions do we have about this? None? So somebody from the Albany campus, what would we do if this was the same scenario? The patient was on fluconazole, except she was on it for 7 days, and the last time that she came into your clinic was 4 days ago, and her INR at that time was 1.7. And let's say her goal range is 2 to 3. So I'll repeat that question. So she's on fluconazole for a whole week. The last time she came to your clinic was about a week ago, and her INR at that time was 1.7. What would you do?
Maybe you do a 10% reduction instead of 20, or maybe less than that since her INR is low.
Perfect. I think that's very reasonable. So definitely taking into account her individual parameters and adjusting based on her as an individual. So either one of those would be appropriate depending on when you were able to bring her back and things like that. Okay, so let's talk about patient case LD. So she takes warfarin 75 milligrams a week. She can't really remember how much she takes on which day. The patient is the hospital is initiating the patient on amiodarone 400 milligrams daily, and she consults you for the management of the patient's warfarin while she is admitted. What are we going to do? Someone from Savannah. This is one of those must-know percentage reductions, right? So how much are we going to reduce her warfarin by? Go ahead.
30 to 50%.
Absolutely, 30 to 50%. So this is a big one. Perfect. So she's discharged on the amiodarone 400 milligrams daily. She follows your recommendations for the changes in her warfarin. 2 months later, she comes to your outpatient clinic after having a stable INR since starting amiodarone. Her INR today is 1.6. She insists to you that she is still taking the amiodarone. What's going on? Someone from Augusta, what could be going on? She's still taking her amiodarone, but all of a sudden we see a drop in the INR. Why?
She said she doesn't know which dose she takes on which day of the week, so her adherence to the warfarin may be bad.
That's definitely a possibility. That's a good point. Someone in Savannah said maybe changes in her diet. That's also a good point, and we'll talk about that. The other thing is, remember I said before to always ask your patients if their doses have changed, as well as whether or not they have simply started or stopped taking a medication. I want to highlight that with amiodarone specifically because amiodarone is associated with a loading dose, and then that loading dose is dropped to usually 200 milligrams a day after 2 to 4 weeks. So it's not the same for every patient. It depends on the response. Sometimes it can even be longer, so this is a big one, where not only do you want to ask them, have you started or stopped amiodarone, but have you had any dose changes in it? So that's something to keep in mind. Okay, a year later, she's coming to your outpatient warfarin monitoring clinic, and she advises you that the amiodarone has been discontinued by her cardiologist. And remember that when she started on the amiodarone, we reduced her warfarin by 30 to 50%. So does amiodarone have a short or a long half-life? Someone from Augusta? Long. So 58 days. So that's very long. So we would not bring her warfarin dose right back up to 30 to 50%. I have a patient right now in clinic who was discontinued from amiodarone at this point a month and a half ago, and her number is just starting to change now. So I basically have her come in every 2 weeks and bump up her warfarin dose little by little, okay? So that kind of specific finagling of the warfarin dose can definitely come with experience and things like that. I don't want you to have to worry about how to do that exactly, but to make sure that you're aware of the initial dose reduction and that you probably wouldn't bump them right back up if the amiodarone was stopped, but that it would be gradual because amiodarone does have a very Sound good? We'll come back to this one if we have time. I want to touch on some drug-food interactions. Alcohol. Alcohol is a big one. This is a red arrow. So this is going to be because alcohol is also metabolized through your liver. So acute alcohol consumption, so somebody who drank a little more than usual last night, maybe had a family party or something like that, you're probably going to see their INR shoot up the next day, maybe for the next few days. Chronic alcohol intake can sometimes lead to a higher than usual dose of warfarin necessary to make a patient therapeutic, just because of kind of those long-term cirrhotic effects of the liver. So I'll kind of repeat that again. So acutely, alcohol consumption can shoot up your INR. Chronic long-term alcohol consumption can sometimes lead to higher than usual doses of warfarin necessary to get people in a therapeutic range. But for the most part, you're still going to see that patients who are drinking a ton of alcohol and then stop, that you're probably still going to need to adjust their warfarin dose. So keep that in mind. You want to make sure you're monitoring things closely and fostering open and honest relationships with your patient. You want to make sure your patient feels comfortable coming to you and talking to you about their alcohol use and things like that. Cherries and cranberries can possibly increase the INR. We're not worried about a little bit once in a while, but a huge amount will definitely affect the INR, and also be aware that a lot of juices and supplements do contain cherries and cranberries. So Purple Arrow, something to be aware of. You may not do an adjustment right off the bat, but if you see somebody who's usually stable, whose INR is a little bit high, maybe ask them, has your diet changed? Have you had any cherries or cranberries this week? That's not normal for you. With all of these diet things, whether that's alcohol, cherries, or vitamin K, consistency is key. So if you have 3 drinks a day for the purposes of the warfarin, that's fine, but you need to always have 3 drinks a day or let your clinic know right away if something changes. So same with cherries and cranberries. If you love cranberries and you have 3 glasses of cranberry juice a day, that's fine. Just don't stop doing that, because if you do, we're going to see changes in your health. Vitamin K containing foods. So obvious here, I would think what we're worried about with the changes in the INR. So for someone from Savannah, vitamin K foods, is this going to bring us down or
Down.
Yes, absolutely. So this vitamin K is going to be working against the warfarin. It's definitely going to potentially bring the INR down. Our green leafy vegetables are what we think of the most. I've put a few things here that may be less well known to contain vitamin K. One of those things is mayonnaise kind of interesting. Miracle Whip does not contain a lot of vitamin K, so that's kind of a safe alternative. A lot of black and green teas contain vitamin K as well. So keep that in mind in some of these other options or other things here that may be less commonly thought to contain vitamin K. But most patients are aware of their leafy greens and things like that. They call them that will bring their number down. Again, this is a big one. Consistency is key. Those are kind of our two biggest hallmarks when we're talking to patients who have either a low or high number that's not normal for them. Have any of your medications changed, and has your diet been consistent? And we'll talk about a few patient cases for examples too. I do want to touch briefly on drug-disease state interactions. Remember we talked about hypo and hyperthyroidism, how this is not only a medication thing with levothyroxine that we're concerned about, but that it is also a disease state interaction. We talked a little bit about these other things, renal dysfunction and liver dysfunction. Remember, warfarin is excreted renally and it is highly hepatically metabolized, so that's why we're going to be worried about this. Cancer, so cancer puts patients at a hypercoagulable state, so more likely to have clotting. And remember also that our DOACs, our newer agents, have not been studied and should not be used routinely in patients with active cancer. So these are patients that you're almost always going to see on DKA or warfarin therapy. So let's talk about a few assessment questions here. So RT comes to your clinic and is very excited about his new diet. He started to have green smoothies 2 times a day. This is a big change for him as he was not previously eating any vegetables. He's been stable on warfarin 14 milligrams a week for the last 3 years. His INR comes back at 1.5 and he is frustrated. He doesn't understand how his numbers are worse if he's trying to be healthy. Can somebody from Athens give me an idea of what you might say to RT? Somebody from Athens, why is RT's number low all of a sudden if he's been stable for quite some time?
He needs to be counseled on the leafy greens and such about the vitamin K intake.
Yeah, absolutely. So what are we going to tell RT to do? Are we going to tell him to stop having the green smoothies?
I would congratulate him on his healthy diet and encourage him to continue it and tell him the importance of continuing like twice a day or whatever he's doing.
Perfect. That is absolutely correct. So we're going to say, just like you said, that's awesome. We encourage healthy lifestyle changes and things like that. Keep doing what you're doing. Make sure it's consistent. We will adjust the warfarin to make sure that it meets your new diet. Let us know if something changes. Probably have him come back in maybe 1 week or 2 weeks rather than 4 weeks to make sure our adjustment to his warfarin work. So maybe I might bump him up 10 or 20%. So I might say, okay, let's give you 2 or 4 more milligrams a week. See you back in a week and a half. See how your number is. Make sure you're still doing the smoothies, and then go from there. Sound good? Okay, so warfarin reversal. I just want to touch base on that quickly since we are talking about fluctuations in INR. You might sometimes see INR that is very high. That's either going to be treated with Kcentra or vitamin K. Be aware of your institution's specific algorithms. I put one that's commonly used as an example here. We really don't worry about, we hold doses for INRs that are between 4 to 5 and 10. We really don't start administering things until our INR is greater than 10. So if an INR is greater than 10, we want to do oral vitamin K. If our INR is greater than 10 and we have major bleeding, that's definitely going to be an IV vitamin K or a Kcentra situation where we need to reverse things quickly. Same if the patient was going to be having surgery. Okay, so we'll quickly look at this question. So Casey comes to the clinic. His INR is 7.2. He had a little bit more fun than planned over the weekend. So an INR of 7.2, someone from Savannah, from what we just talked about. Are we going to give him vitamin K? Let's say he's not having any signs or symptoms of bleeding. No. Okay. We talked about this extensively when we went over the alcohol. Basically want to make sure that you're eliciting social history from patients. This case is an example of a patient who stopped drinking and saw a drop in their INR after they stopped drinking. So if somebody is coming off from a lot of long-term alcohol use, you probably are going to have to start bumping up their dose of warfarin. And exactly what that percentage is going to be very patient-specific, but you want to make sure that you are taking kind of all of that into consideration in terms of the things we talked about with adjustments and patient-specific parameters. So kind of to recap with some clinical pearls, you want to make sure you're educating patients on consistency. Follow-up for the guidelines can be up to every 12 weeks. 4 weeks is probably more usual. The guidelines do not routinely recommend boosting. So for 1 out-of-range INR in a usually stable patient, what that means is as long as it's not greater than 0.5 out of range in either direction, that you probably wouldn't boost them routinely. So if somebody comes in, they're usually stable, the range is 2 to 3, and they're 1.8 today, maybe because they had some more greens over the weekend, probably not going to give them extra warfarin. Just return to your usual diet and continue on. The only time that we really make changes in the warfarin when it comes to diet is if somebody's going to be making a permanent diet change, like the case that we talked about. Okay. So in conclusion, there's a lot of medications, food and disease states that do affect warfarin and our management of warfarin. Make sure that you are invoking an appropriate history from your patients and try to start delving into the literature behind the recommendations of warfarin adjustments with all the issues that we talked about today. Thank you so much for everyone's time. Does anyone have any questions?
Yes, Dr. Keedy, I have a question from Athens about warfarin plus low-dose aspirin. Would that ever be something that you would see and you would continue the patient on that?
Yeah, so there are some scenarios in which warfarin or anticoagulation in combination with a low-dose aspirin is appropriate. Actually, the new test guidelines, like I said, that were just released a month ago, did kind of change some of the situations in which that is most appropriate. But I can give you one example of when it would be appropriate. If you had a patient who was on warfarin therapy for, let's say, a DVT or a PE, and then they had another event or another clotting event, that is an example of a type of patient that you would, at that point, probably add aspirin onto to prevent an event because they had an event while they were on warfarin monotherapy, and for whatever reason, it was not enough. That being said, some of the new literature is frowning upon aspirin.
Good morning.
Let's go stuff right there.